Okay, this section deals with pneumonia. Now, pneumonia is the infection in the lung parenchyma, and that is because of two main reasons. That is the impaired local defense mechanisms. Secondly, due to the lowered systemic resistance, the immune compromised states of the patient, as in the transplant patients or in HIV patients, the leukopenia that causes the decrease in the white blood cell counts, then some chronic diseases that also predispose even in hospitals, when the patient are on the certain group of antibiotics and they are debilitated patients, then the various catheter indwelled patients are at high risk of death due to pneumonia. As I've already mentioned, the local defenses are impaired in case of the pneumonia, and the cough reflex is impaired. The mucociliary apparatus is also not working properly. Usually, the virals causes the primary URTI, and that has the bacterial superinfection. But in certain population, like in cystic fibrosis, the mucus is thick, and that causes the failure of the mucociliary apparatus. Now, in the alcohol drinking patient population who have heavily drunk, they have the gastric aspiration is common in them, and in smoking population we have the failure or the decreased mucociliary function, so that also predisposes. Then the acute lung injury or O2 injury, even the pulmonary congestion and edema are all risk factors that cause the bacterial growth, and they create a area, the environment for the growth of the bacteria and for the pneumonia. Now, the second mechanism is the impairment of the host defenses, and host defenses, the particular importance is NFkB. So NFkB is the molecular switch, and its activation is very much necessary for the immune response. Now, the gene which maintains the NFkB activation is MyD88, and its dysfunction is one of the important causes for the defective host defenses. Now, the congenital deficiency, immunodeficiency can be there or acquired, as in case of the HIV patients. Most of the time, they have infection of the Pneumocystis jirovecii and Pneumocystis carini. We will look this again as we move forward. Now, the types of pneumonia are based on the clinical settings, how we acquire the pneumonia. If in the community, it's called community acquired pneumonia. If acquired during the stay at hospital, it is called hospital acquired pneumonia or HAP. Then healthcare associated pneumonia, if the patient has a history of 2 days back going to the nurse clinic or to the hemodialysis center, even the intravenous antibiotic therapy, chemotherapy. Okay, so that is healthcare associated pneumonia, but we also classify pneumonia based on morphology, and this is important classification. The lobar pneumonia, usually caused by bacterium, as the name suggests, involves the lobe of the lung. A single lobe of the lung is usually involved. But in bronchopneumonia, we have something called patchy infiltrate in the whole lung. Then in the atypical pneumonia or the interstitial pneumonia, again, as the name suggests, we can see that the pneumonia or the infiltrates are in the alveolar walls or the interstitium. In contrast, in the lobar pneumonia, the infiltrates are usually inside the alveolar spaces, while here they are in the alveolar walls. Okay, this is also called as the walking pneumonia because it causes fatigue. And mainly the causes of the atypical pneumonia are usually viral causes, and in the lobar pneumonia and the bronchopneumonia, the causes are usually bacterial. Now, the bacterial pneumonia, in the lobar pneumonia, the causes are the streptococcal pneumonia and the Klebsiella pneumonia. Streptococcal pneumonia is most common cause of the community acquired pneumonia, whereas the Klebsiella one is the nosocomial or hospital acquired. Now, the streptococcal pneumonia is capsulated, and the splenectomized patient are at increased risk of its infection. In children, the streptococcal pneumonia causes the otitis media. In treatment, we have the vaccine available for the pneumococcus, but the drug of choice for treatment is actually the macrolides. In Klebsiella pneumoniae, the current jelly sputum is the characteristic feature, and it is common in the chronic alcoholics, and it is a difficult bug to treat, and we use the carbapenem group of drugs. Okay, now the bronchopneumonia. In the bronchopneumonia, recall that we have patchy infiltrates, and here we have the pseudomonas. The pseudomonas is again the gram-negative aerobic bacteria. It is hospital-acquired pneumonia and community-acquired pneumonia, but it is common in the HIV and cystic fibrosis patient, and this is something high yield. in cystic fibrosis patient, they are at increased risk of Pseudomonas infection. It is a difficult one to treat, and we use the carboxypenicillin, the 5th generation cephalosporins, and carbapenem group of drugs. And one more thing, the septicemia is common in the neutropenic patients. Okay, septicemia, recall that it is because of the lipopolysaccharide LPS, that is endotoxin, and that causes the septicemia. Okay, now the Staph aureus is the golden colored cocci, as you know, and that is important in the lung abscess, empyema, and endocarditis. It is most common amongst the secondary pneumonia causes, that is, after a viral infection, the superinfection which is there, it's usually Staph aureus. It is also common in the IV drug users, and in the IV drug users, recall one more fact which is high to know, that it causes tricuspid endocarditis. Okay, then the treatment is with the penicillin, and obviously if it is penicillin is producing bacteria, then we would use dicloxacillin or cloxacillin. If it is methicillin resistant, we prefer vancomycin, and if it is versa, then we use linezolid. Now, the other causes of the bacterial pneumonia are the Legionella pneumophili, that causes the Legionnaire's disease, Pontiac fever, and it is common in the aquatic settings. This is very high to be aware of. It is also common in the immunosuppressed patients, and the drug of choice for it is macrolide and fluoroquinones. Now we have something which is exacerbation of the COPD in the Legionella, and the Legionella is not only the one organism that causes the COPD exacerbation, but we also have two other important causes to be aware of, that is H. influenza and Moraxella catarrhalis. So three main reasons of the Legionella, H. influenza and Moraxella catarrhalis, that exacerbate the pneumonia. The second thing to be aware of is the H. influenza, and H. influenza is encapsulated bacteria, and that can be also non-capsulated in certain settings. Okay, that causes the upper respiratory tract infection, bronchopneumonia amongst children, high yield to be aware of. Bronchopneumonia amongst children, and otitis media also amongst children. Okay, so there are three causes of the otitis media here which we have discussed. So that is the otitis because of the H. influenza, otitis because of the Moraxella, and otitis because of the strep pneumo. Okay, recall we have discussed earlier. Now in old patients, we have the sepsis by the H. influenza, or pyelonephritis or suppurative arthritis. We also have a vaccine available for the H. influenza, and that is for the B serotype. Recall we have HIB vaccine available. This is in contrast with the meningococcal vaccine that is not available for the B serotype. Now, the Moraxella catarrhalis causes the otitis amongst children. It is rare cause of the pneumonia amongst the children. Drug of choice for the Moraxella catarrhalis would be amoxicillin plus clavulanic acid. Now the atypical pneumonia. Recall I have stated that atypical pneumonia is mainly caused by viruses, but we also have the bacterial causes. So the first one is the Mycoplasma pneumonia. It is the most common cause of the atypical pneumonia. It is more common among the school-going children and camps and prison. You can see that these are the closed areas. So closed dorms or closed areas are increased risk of Mycoplasma pneumonia. Therefore it can cause also the local epidemics. Okay, then the drug of choice is macrolides for the Mycoplasma pneumonia. Then we have the Chlamydophila pneumophili, that is seen in the older age group and the young adults. Then the drug of choice is also the macrolides for chlamydia. Lastly, we have the Coxiella burnetii. Now, Coxiella burnetii is actually a rickettsial organism which was recently separated. Now, why it was separated? Because it has no arthropod vector and it causes no rash. That's these 2 points are differentiating one. And so how it is carried? It is actually carried by the spores of animals, and from the spores of animal via the respiratory droplets, it infects the human. Now, another high to be aware of for the Coxiella is the hepatitis. Usually, the bacterial pneumonia causes the headache, myalgia, fever, but in contrast, it also causes hepatitis. So this is what it differentiates from the other. It also causes hepatitis. It is very common in the farmer population because they deal with the animal spores and the animal dung droppings and all. Veteran also deal with the droppings and all. Now, how to differentiate it with brucella? So brucella has a undulating fever. That is the difference. The brucella has an undulating fever, while here we have the characteristic feature of hepatitis also. Okay, so that would be for the atypical pneumonia. Now the stages of the lobar pneumonia, the first one is the congestion. It is seen in the 1 to 2 days after infection, wherein the edema fluid builds up in the alveolar air spaces. We have the stage of red hepatization, where the RBCs, neutrophils and the fibrins build up, thus giving the lung an appearance of liver-like consistency and color because of the RBC specifically. Then when the RBCs start to break, we have the gray hepatization. Finally, we have the stage of resolution in the about around in the 3 weeks, and that is usually after resolution, when the macrophages take the debris and the fluids start to decrease in the alveolar spaces and normal architecture is being restored. We also have the fibrosis, but fibrosis is usually when the pleurisy or the pleuritis is associated with the pneumonia. So this is the chest X-ray for the lobar pneumonia. Look here, we have the lower lobe of the right lung involved. Okay, this slide represents the stage of congestion, and as you can see, we have the alveolar infiltrates. Then we also have the edema fluid, the tons and tons of neutrophils. Next, we have the stage of red hepatization, and this area can be seen with the different contrasting features of the normal lung parenchyma in comparison to the stage of red hepatization, where the RBCs are present along with the neutrophils and the fibrins. Now, bronchopneumonia, as I've already stated, the bronchopneumonia is the another morphology feature of the bacterial pneumonia, and it involves the patchy infiltrates of the lung parenchyma and is multilobar. Then it involves bilaterally, usually the lower lobes, because the gravity tends to accumulate the fluid in the lower lobe. Okay, here you can clearly see the patchy infiltrates, acute suppurative inflammation in the lung parenchyma. So this represents the bronchopneumonia. Complications of the bacterial pneumonia, the abscess formation would be there, or the pneumonia can spread to the surrounding structures like the pleural cavity, and that may lead to empyema. It may also disseminate systemically to have the heart valves involvement, pericarditis, endocarditis. Meningitis is a severe complication. It may also be fatal. Now the atypical pneumonia, I have mentioned, it is mainly caused by viruses, but it can also be caused by Mycoplasma pneumoniae, Chlamydophila pneumoniae, and the Coxiella burnetii. Okay, now as I've mentioned, that virus is primarily involved, and what they do is that they cause upper respiratory tract infection, they cause the failure of the mucociliary clearance, and this in turn causes increased risk of the bacterial superinfection. Now, influenza virus, the influenza virus envelope consists of the neuraminidase and the hemagglutinin, and the two high to be aware of about the influenza are the antigenic drift and antigenic shift. So what is antigenic drift? Drift involves only a point mutation. So it only involves a point mutation in the neuraminidase and hemagglutinin molecules. So for the drift, even if the structure is changed, it would be a little bit, and we would have immunity for the change structure, because there is only a slight change required in our immunoglobulin molecules also. But in case of the antigenic shift, what is happening is that, let's say for example, we have swine flu. So in swine flu pandemic, what happened was that in the pig influenza and in human influenza, there was exchange in the Na and Ha molecules, that is neuraminidase and hemagglutinin molecules. So this caused a drastic change in the antigenic structure and its resistance, of course, because we can't change the whole structure of the immunoglobulin in one time. So that causes it to be a pandemic. So antigenic shift is dangerous and it causes the pandemic, while drift is usually which is in our control, and usually it lasts for a week. Now, what is the general mechanism by which the influenza virus works? It inhibits the sodium channel, and that causes the fluid accumulation. This in turn causes the bacteria to grow because they have a favorable environment. Then the presentation of the influenza is as upper respiratory tract infection, headache, myalgia, and fever. All these are non-specific symptoms. Respiratory syncytial virus is another one to be aware of. It classically affects the children less than 2 years of age. This is the differentiating point from the human metapneumovirus. that is human metapneumovirus, which is in the same family, and that the human metapneumovirus usually involves the immunocompromised hosts. Okay, and we have the pevalizumab, that is the monoclonal antibody against the F protein of the RSV. This is the chest X-ray of the interstitial pneumonia, and as I've already stated, as the term implies interstitium, so we would see the alveolar infiltrates in the interstitium or the alveolar walls. Okay, so here we can clearly see the infiltrates present in both the sides of the lung field. Okay, so this is the classical picture. Similarly, in the histology also, we are able to see that the alveolar space is actually free while there is diffused infiltrate in the walls of the alveoli. This is again the feature of the interstitial pneumonia. Okay. Now the presentation of the pneumonia. The bacterial pneumonia classically presents with high fever, chills and cough. While in viral pneumonia, cough is usually absent because remember we have the failure of the mucociliary escalators mechanisms. The symptoms are non-specific upper respiratory tract infection, fever, headache and myalgia. Now another classic feature of the bacterial pneumonia is pleuritic pain, which is because of the pleuritis, and because of the pleuritis it's because of the bacterial dissemination and spread to the local areas. Okay. Okay, now aspiration pneumonia. The aspiration pneumonia, as the name suggests, involves the aspiration of some content. Now usually the content is gastric content, and the gastric content is usually taken in when we have the failure of the gag reflex and the swallowing reflex. And when these reflexes are failed, yes, you're right, they are failed in the alcoholic patients, in the drugged patients, in the comatose patient, or even in the stroke patients. Now, what is the complication? If the aspiration pneumonia resolves, then also there may be a complication of the lung abscess. Most of the time, high to be aware of, right lower lobe is involved. Why? Because the right bronchus, mainstem bronchus, is more oblique, and so it's easy for the things to go downwards via this path rather than a horizontal left bronchi. So first of all, the right side is involved. Now why the lower lobe? Obviously again because of the gravity, the fluid tends to accumulate in the lower lobe. Now in the chronic pneumonia, we have three organisms which are fungus, histoplasma, coccidioidomycosis, blastomycosis. A bacteria is also the Mycobacterium TB, which is high to be aware of, and we are going to discuss it in the following slide. Now histoplasma is intracellular, and we can remember this by thinking that the histoplasma size is lesser than RBC, and the macrophages, whenever they are capable of phagocytosing this histoplasma, and so tens and hundreds of the histoplasma are seen in the macrophages. Now in contrast, the coccidioidomycosis is larger than the RBC, and the blastomycosis have same size of the RBC. So yes, you can think that they are not actually phagocytosed by the macrophages, because recall the size of the macrophages is almost similar to the RBC. Okay. Now the histoplasma is common in Ohio, Mississippi and immunocompromised patients. Actually all the fungal infections are common in the immunocompromised patients. They are actually more clinically they are visible, while these infections are usually subclinical in the immunocompetent patients. Now there is granuloma formation in the immunocompetent patient, while there is dissemination in the immunocompromised. Okay, the spread is by the spores of the bat and the bird droppings. Now this spores spread is also seen in the coccidioidomycosis and the blastomycosis. Now coccidioidomycosis. So coccidioidomycosis is common in the southwestern USA, and it has a dimorphic state. What is dimorphic state? Means there is different kind of structure in the different temperatures. One crazy way to remember this is that mold cold and yeast heat. So mold in the cold temperatures it is in the form of mold, while when in the body or in the presence of heat it is in presence of the it is in the shape of yeast. Okay, now the size is greater than RBC, which I've stated. It can also cause skin infections, meningitis and arthralgia. The next one is the blastomycosis. Blastomycosis is southeastern. Okay, it is southeastern of the USA. Then it is also dimorphic fungus, and it involves the multiple nodules in the chest X-ray, and its size is same as RBC. Now Mycobacterium TB. TB is a acid-fast bacilli. It is common in the HIV population, particularly the secondary infection, because the latent infection is activated when the CD4 counts drop. Now the spread is obviously by inhalational route, and rarely it's by oral route also. The primary infection, when there is infection by the first time and the secondary infection when there is the activation of the latent organisms or when there is reinfection. Now, in the primary TB, the exposure is first time. Classically, it involves the lower part of the middle lobe and the upper part of the lower lobe. Then there is formation of the Gons complex, which is the caseating necrotic center. But usually it forms a hard tubercle. And what is Gons complex? The Gons complex is formed when we have the lymph node, hilar lymph node involvement and the lymphatics involvement along with the Gons focus. So it makes the Gons complex. Now when the Gons focus is calcified, it is called Ranke complex. Usually the primary TB is asymptomatic. However, since the cell-mediated immunity is working and response is there, so PPD would be positive. Remember, the false negatives are there in the HIV patients where the TB is there, but cell-mediated immunity is not working, so PPD is false negative. In the secondary TB, we have the reinfection or reactivation of the latent TB. Now, classically, it involves the apical lobe. Now, here I would like to stop and say why the apical lobe. Because in the apical lobe, the ventilation is greater while the perfusion is less. So, good amount of oxygen is available. And guess what? The TB bacteria is an aerobic. It's actually an obligate aerobe. So, it prefers to be activated in the apical lobe. Now there is formation of the soft tubercle. Soft tubercle, in contrast to the hard tubercle, has a soft caseating center, and classically it is subpleural. Subpleural necrosis is seen. The complication of the secondary TB is the miliary TB. It's a severe form of the TB where there is bacterial dissemination throughout the body. There is multi-organ failure, so it's an emergency. Now the patient of the TB classically presents with hemoptysis, mild fever and night sweats, and weight loss. Another characteristic feature to be aware of. Usually when there is weight loss, you suspect either malignancy or you suspect the TB, at least in the developing countries. Now in the diagnosis, it's based on the culture. If culture is negative, then we would go for the CBNAT and the CXR. Okay, so CBNAT is a PCR test, gene expert test, which is based on the PCR, and chest X-ray of course remains one of the standard protocols. Now the biopsy, we would see the caseating granuloma, and to differentiate it from the fungal causes, we do the acid-fast staining where the TB will look bright red. Now the complications or the extrapulmonary TB usually seen after the latent infection or the reactivation or even the reinfections. Now meningitis is the one of the fatal complications, and it usually involves the base of the brain. The most common site is the kidney, and it involves the sterile pyuria. The next one is the port spine. It involves mainly the lumbar bodies. It can lead to hunchback. Now the cervical lymph nodes are also involved, and it may lead to lymphadenopathy. Here you can see in the chest X-ray the Gons focus. Okay. Now the HIV and the pneumonia are very high to be aware of, because it's based on the CD4 count that the pneumonia usually etiology of the pneumonia is dependent. So if the CD4 count is greater than 200 per millimeter cube, we have Mycobacterium TB, Staph aureus, Staphylococcus pneumonia, H. influenza, or gram-negative bacteria like Klebsiella, Serratia, and all those infections. Now if the CD4 count is less than 200, then it's Girovasi and Carini. These are the fungus. Then if it's even less than the 50, then it is fungus, usually Aspergillus or Candida, cytomegalovirus, and Mycobacterium avium complex. Okay. The diagnosis is based on the C-reactive protein and the procalcitonin, which are the acute phase proteins and elevated in the bacterial infections. The chest X-ray can give us the finding about the interstitial pneumonia, the lobar pneumonia, or the bronchopneumonia. Finally, the clinical symptoms are obviously seen in both the viral and the bacterial pneumonia. They are more specific in case of the bacterial, where we have the fever with chills and the coughs and even the pleuritic pain. That's all for the pneumonia, guys, and hope you liked it. Subs if you loved it. I actually uploaded video after a long time. Actually, I had some exams going on, so we would be continuing from here on every week the lectures. Okay, bye for now.